have cervical incompetence, and there's a risk of ectopic pregnancy or corneal pregnancy in this septate uterus where the pregnancy sac is very in the position. 50% of the patient may have no complications from the obstetrical point of view. They have a high association with urinary tract abnormality. So whenever we pick up an ABA, we should always look at the kidney. There are multiple anomalies which we can pick up. Here's one such patient who had a heavy uterus and a single pelvic kidney. This was another patient who had a hypoplastic uterus, had endometriosis, and had bilaterally rotated kidneys with duplication of the collecting system. Accurate recognition and classification is very important for effective and efficient planning of therapeutic strategy. To improve the reproductive outcome, the miscarriage rate decreases to about 15 to 20%, and the term delivery goes up if it's a good septal resection, as in this particular patient we can see. Also to help to minimize complications like endometriosis and infertility. Now it's very important to classify them. ASIRM is the oldest classification, and this combines the degree of developmental failure with clinical manifestation. H3 classification is the newer one, and there is the uterine anatomical deviations derived from the same embryological origin. And then there is the newer classification system which was proposed by using this congenital uterine malformation by experts. They have a methodology that defines these cutoff points which are based on the diagnostic test accuracy. The ASIRM major drawback is that it does not specify the uterine morphology. H3 classification has an advantage that uterine anatomy is the primary base of systematic categorization, clinically oriented with prognosis correlating to the type and degree of anatomical deformity. The mode of classification sorts of classes and subclasses according to the increasing severity. Use of absolute numbers is completely avoided, and because we know that each uterus varies with each woman, so the uterine wall thickness varies from patient to patient. Also, the advantage is that normal uterus and the cervical and vaginal anomalies are classified independently and are included in H3 classification. Now, these are 4 different HSUs, and this is pretty normal. It's a very good test for tubal patency, but it also gives the uterine contour deformities. Now, here's one such patient who had 2 cannulas. So, looking at this, we would always say that it's a uterine diabetes or bicorporal uterus. And this actually I very recently did. And this looked like a heavy uterus. I was pretty confident. I said, okay, let's go ahead and do a 3D and see what happens. So, when we did a 3D image, the coronal plane shows a normal uterus. And this, to my surprise, which I think still is a normal fundal contour. So, this was a complete septate uterus. And this patient actually had a bicorporal uterus because the fundal contour was normal, but the 2 uterine cavities were far apart. So this patient actually would have benefited if we had tried doing this, but I'm very anti that unless we do a 3D, because as in this particular patient, it was heavy uterus, and this was in earlier days, and we used to have the OBGYNs come to insert the cannula. And so she insisted and I refused, and I'm glad I refused because I don't know how much damage she would have created if we had gone in to put the second cannula. Transabdominal ultrasound is not the modality of choice, but we still do it. It's very helpful, especially if the bicornuate uterus where the 2 cavities are far apart. And it also does help in this young girl who did it, and this was a partial septate uterus. Endovaginal ultrasound sensitivity is about 100% and specificity is about 80%, and here we can see the 2 endometrial cavities. Long axis is not giving us any information, but unless we do a 3D, we don't get an answer. And we do a 3D and the coronal plane shows that it's a partial septate uterus. Here we have this, so we can see that there are 2 endometrial cavities, and when we do a 3D, it gives us enough information that it's a complete septate uterus. Septum is coming all the way to the cervical os. And rendered image gives us the same information, but it's nicer to see this image. And here's another patient who actually on the long axis and transverse view, we would have completely missed it if we didn't do a VCIC plane where we found that this is a heavy uterus. This was the same patient on multiplanar images and a rendered view. Now, coronal images are very good to delineate Mullarian anomalies because you can look at the fundal contour and we can also look at the internal indentation on the endometrium. And in this patient, the 2 cavities are very far apart. VCI is an easy, very easy to do. It outlines the deformity by tracing the endometrium, which can be traced in the long axis, it can be traced in transverse view, and so these are two separate patients, the septate uterus and the heavy uterus. So this was actually studied by a group of experts and who recommended that coronal images and the VCI is an easier way and it's recommended for MBA evaluations. The vocal software, we can do the volume calculation, which is more accurate. We can also do the endometrial cavity evaluation, and this actually plays an important role when we are evaluating women of unicornuate or uterus. Now, vascularity shows if there's increased vascularity in the septum, that can affect the fertility prognosis. We can use this cut section to see the region of interest in the hemiuterus, and this is a septate uterus. And TUI gives the entire extent of the septum. Timing again is very, very important. There are two different patients done on 4th day, 7th day. And actually here we are suspicious. Here also we can see a unicornum, but the endometrium was not that well defined. And on 14th day when we do it, we can confirm that it's a heavy uterus. And this was a bicorporal uterus. Now there are certain definitions which we should know when we are trying to diagnose MDAs. We draw this interosteal line, which is from one intercornual line or interosteal line from the edges of the cornua, and then this is then we do the indentation depth. From the interosteal line, we drop another line, which is the distance between the interosteal line and the lowest part of the endometrial cavity. That's called the indentation depth. Indentation angle is measured tracing two lines close to the indentation apex. Then external cleft is we draw the interosteal line, and from the external cleft we drop this distance. This distance is the external cleft. Wall thickness can be measured in the sagittal plane, and we measure the maximum thickness of the anterior and posterior uterine walls. And we take the mean of the two. It can also be measured in the coronal plane, where we draw the intercornual line or interosteal line, and then we draw the one on the frontal contour and we measure this distance, which is the wall thickness. External fundal contour is very important when we are trying to differentiate MDAs. Now, if we have two images like this, here we can see that the fundal contour is dipping below the endometrial cavity, and here it's nice and convex. So this, we cannot go wrong by saying this is normal fundal contour and this is abnormal fundal contour. So there is this particular group who came up with this method to evaluate external contour in patients which are difficult. Now, this is one patient where we draw the interosteal line and the fundal contour is still not dipping below the endometrial cavity. When we connect this distance here or measure the wall thickness, it's less than 5 millimeters, so it's abnormal. And in this particular, it is dipping below the uterine endometrial cavity, so this is actually abnormal, and this was a good way of evaluating these. This is just a normal uterus. There's normal fundal contour, there's flat anterior margin, there's a triangular endometrial cavity, there are two interstitial segments of the fallopian tube, and there's a minimal indentation which may be considered normal if it's less than 50%. Now, H3 classification, because it includes it, is class 0. These are three different patients which show mild anterior depression along the anterior endometrial cavities, and the fundal contour is normal in all this. Now, if we look at H3 classification, this is all normal uterus. But if we look at the arcuate, or if we look at the ASRM classification, they are called arcuate uterus. And then if we look, what I'd like to do is add this to CUME recommendations. Indentation depth less than 10 millimeter. 50% uterine wall thickness at the fundal midline, and the indentation angle more than 90 degrees. And that actually tells us it's an arcuate uterus. And the external fundal contour is normal, and a minimal indentation less than 10 millimeter is considered normal. Now, T-shaped uterus is narrowing of the endometrial cavity. It was first described drug-related due to this drug which is not used anymore. So here we have an HSC which looks like a pretty much deformed cavity, and the name of T-shape came when there was a uterine cavity which looks like a T. Now, H3 classification subjectively defined T-shaped uterus, whereas CUME came up with the objective criteria. So what happens here is there is narrowing of the endometrial cavity because of the lateral wall thickness, and the fundal contour is normal. There are two interstitial segments of the fallopian tube, But this could also be due to tuberculosis, which is a distorted cavity. It may be acquired in this particular patient, where there was a fibroid also. And this actually had a fibroid which was giving a T-shaped uterus and also had adenomyosis. So the H3 class is subjective evaluation. The other important thing when we are trying to diagnose T-shaped is the ratio of the uterine body to cervix. Uterine body is 2/3 as compared to 1/3 cervix. The CUME, this thing is they give some measurements. Now we draw a line from the cornua to the apex, and then we, from the cornua to the internal os, and we draw this line and measure from the apex to the maximum distance, and that is called the lateral indentation depth. Lateral indentation angle is from this particular apex when we go 5 centimeter up and 5 centimeter down, and we measure this angle, which is the lateral indentation angle. Then there is T angle when we draw from one end of the cornua to the other end, and then we draw another line which is connecting this apex, and this is the T angle. Now, this has a good diagnostic test accuracy and a fair to moderate reliability. There are certain numbers which are given. I myself don't remember it. I just keep them with me. When I need it, I just take it out and check it. So when the lateral indentation depth is more than 7 millimeter, indentation angle is less than 130, and T angle less than 40, it's called a T-shaped uterus. Borderline is when there's a presence of 2 of these criteria. Like in this particular patient, it's a borderline. Here, in this third image, there's only one criteria which is met, that is 8 millimeters. Rest of them are in the normal range. So this is considered a normal uterus. Then there's the uterus infantilis, which is narrowing of the uterine cavities without lateral wall thickening. Now here the ratio of the body to the cervix is reversed. Its uterine body is 1/3 and the cervix is 2/3. And these are just 2 different examples of the same hypoplastic uterus. Now, when there's failure of absorption of uterovaginal septum between 9 to 11 weeks, results in septate uterus, which accounts for about 55% of the uterine anomalies. The septum is nothing but this internal indentation from the at the fundal midline exceeding more than 50% of the wall thickness. When the septum ends above the level of internal os, it's partial septate. When it goes all the way into the internal os or goes up to cervix, it's a complete septate uterus. Now, when we are trying to diagnose them, we look for the fundal contour, which should just be normal convex, or a minimal indentation, which is considered normal. There are 2 endometrial cavities, and there are 2 interstitial segments of fallopian tubes. 2D, actually on the transverse views, when we first start suspecting, I think I've talked enough of it, and when we do a coronal plane, it gives us a complete septate uterus, and this is another example where there is a complete septate uterus. Now, according to H3 classification, we look at the septal wall thickness. It should be more than 50% of the uterine wall thickness, and we have already said that we can take the mean of the anterior and posterior wall, thickest portion, or in the coronal plane, we measure from the fundal contour to the interosseous line. CUME has indentation depth, indentation angle, and indentation depth to wall thickness ratio as their criteria. And ASLM has multiple things: angle, indentation, apex, intercornual distance from one end of the cornua to the other, and fundal indentation less than 1 centimeter. This is ASLM classification calling it septate uterus. The reproductive outcome may be very variable. In this particular patient, there's an intrauterine device, so she obviously didn't have a problem of conception. This patient had a septal resection, but it has a very, very abnormal looking attachment to the gestation site. And this was a cornual pregnancy. The smaller the cavity, the poorer the outcome. Here it's a pretty decent sized cavity as compared to these 2. So they have a poorer outcome as compared to this one. Septal vascularity, endometrium covering the septum does not respond to estrogen and results into pregnancy failures. Now, it's very important to differentiate between septate versus arcuate or normal uterus because of the reproductive outcome. So this is normal. Now here we have 4 of these images. This is a pretty normal uterus. We can use any classification, and now we can't go down. And these are the 2 images of a partial septate uterus. Again, using any classification, we know this is a partial septate uterus. But here are 4 different images of the same, and it's hard to say what it is. If we use H3 classification, we will classify all of them into partial sectors. And if we use ASNM, this would be arcuate, and this will be still in the criteria where we may not be able to say it's in a gray zone whether it's arcuate or should we call it partial sector. Then when we add CUMB classification, all these 3 come into partial sector uterus. So that's the advantage I find of TCUMB measurements. Now, there was a study which was done by this particular group, and their study found that prevalence of septate uterus is highly dependent on the criteria used for its definition. There's considerable difference in prevalence according to H3 as well between these 3 systems. H3 classification resulted in overdiagnosis and a high rate of septate uterus, and ASNM classification left a lot of uterine cavities which were in the gray zone. Coming to the next one, which is abnormal fusion or failure of fusion of Mullarian ducts results into bicorporal uterus or uterine diathesis, which is class 3 according to ASNM, and then bicornuate, diathesis or bicornuate according to the ASNM classification. Now there is, what happens here is incomplete or partial fusion of the uterovaginal septum, and then that results into in the 2 cavities, 2 uterine cavities, each having its own myometrium and endometrium, and there's complete duplication as in this system, where there's complete failure resulting into uterine diathesis. There are 2 uterine horns, there are 2 cervices, and 2 proximal vaginas. These account for about 10% of anomalies. These are much better picked up on transabdominal because the cavities are way apart and it's easier to pick them on the transabdominal scan, and they have to be measured as it's hard to do a 3D on these patients. And when we do a transvaginal on these patients, we have to place them separately to call them uterine diathesis. So these cavities have their own myometrium and endometrium. There's an abnormal external fundal contour as well as an internal midline indentation. According to ASNM classification, external fundal indentation is below the interosseous line, as you can see here. This measures less than 5 millimeters. This intercornual line and the fundal indentation, this distance is less than 5 millimeters. And we can measure the intercornual distance. According to H3 classification, we use the uterine wall thickness, which is more than 50% of the midline indentation is more than 50% of the uterine wall thickness. Now, H3 classification further subclassifies these, which is partial bicorporal uterus. There's an external indentation, there's an internal indentation which does not reach up to the cervix or the septum. But there are 2 separate uterine cavities and each are separately seen. Then there is the complete bicorporal type where there is a complete indentation, and this indentation involves the cervix, and there's a longitudinal vaginal septum which is seen in about 75% of the cases. There's a third type which is bicorporal septate type where the indentation does not reach the cervix, but it's combined with the septum, which is more than 150% of the uterine wall thickness. And in these cases, the longitudinal vaginal septum is seen only in 25% of the patient. Now, when we are trying to differentiate between septate and bicorporal uterus, we have to see the fundal contour, because septate uterus generally has a normal convex fundal contour, whereas these bicorporal uterus, they have an external indentation. And this external indentation is more than 50% of the uterine wall thickness. Reproductive outcomes are generally good. There's a risk of second trimester miscarriage is about 40%, and we look for cervical incompetence, as in this particular patient. We can see the internal os opening up, and there's a short cervix. This patient was a young girl. Actually, this was one of the studies which I did long time back. So she had the bicorporal or 2 uterine cavities. One of them was normal, and the other one showed a lot of fluid collection, which was hydrometric. Now, when we diagnose hemiuterus, there is normal development of one Mullarian duct and this complete arrested development of the contralateral duct. So this results in a fully developed functional hemiuterine cavity. There's a single endometrial cavity, there's a single interstitial segment of the fallopian tube, and there's a single cervix. Generally, these cavities are small. They may be located off midline. They have a banana-shaped appearance, and they may have no contralateral horn. That means there's one cavity, there's nothing, no other contralateral horn is seen. They could be divided into rudimentary horn, which is this rudimentary horn may be a functional cavity. Or there is this other type which is unicorn uterus, but it does not have, it has another rudimentary horn, but this does not have a functional endometrial cavity. We can see when we compare these two images, we can see the endometrium very nicely here, and here is very poorly developed. Now this was one patient who actually came for confirmation, came for ovulation study actually. So she had this with an ability to conceive, but this was a heavy uterus. She also showed a very, very thick endometrial cavity which was very vascular. So she, fallopian tube. So she had increased vascularity, and this was salpingitis. This was another patient who had recently got married and came with severe pelvic pain, shows a unicornuate uterus. There was a large fluid collection posterior to this cavity. There was a bladder in this. And it was difficult to say whether we are dealing with another uterine cavity or is it just hydrosalpinx. And on surgery, it turned out to be hydrosalpinx. Now, this patient had hemiuterus, and there was also a submucous fibroid which was associated with endometriosis. And this is a 30-year-old with multiple missed abortions. This was amazing. I don't know why she just went on doing every 3 months she would get pregnant and have a missed abortion. This was the first time when we did her. She came to us till 12 weeks when the pregnancy was doing very well, and this was when we picked up that this was an endometriosis. But she didn't come after 12 weeks, so I don't know what happened to her. That was one of the problems which I faced in private practice. And this patient I recently done, and she hasn't come back for a follow-up, but this shows a rudimentary one. It's a unicornuate uterus deviated to one side, there's a gestational side, and there's a communicating right horn. Now, aplastic uteruses, when there's early developmental failure of Mullarian duct, which results in agenesis or hypoplasia of the uterus, cervix, and proximal two-thirds of vagina. And this is associated with this particular syndrome. I have a very hard time pronouncing this. And generally, they have an absent uterus, they may have normal ovaries, and there's a normal karyotype. And they can have aplastic uterus without any cavity, but this had a rudimentary cavity. The cervical anomalies, when we look at the cervix, this is normal. But in this particular patient, the same has two separate cervix, a double cervix, and this distance between the two cervixes increases and thickens. When there's a septate cervix uterus, there could be a single cervix, there could be two septate, the septum may extend into the cervix, giving two complete septate uterine cervices, or there may be, as we can see here, the septum, complete septate uterus with two cervices and two vagina. This was a septate uterus which was associated with hydrocorpus, and you can see on the color flow showing temporal vessels. And this was no cervix at all in this particular patient. So the degree of confidence in diagnosing MDA with these is very good. It's when we do a coronal plane, the specificity and sensitivity is almost 98 to 100%. As compared, so when we compare it to MRI, it is almost similar. So my recommendation is we should do this first and then do an MR to see if needed. I don't clinically recommend it. Now coming to this, the first slide, I hope we can all diagnose it by this time. The HT classification, normal, T-shape, hemiuterus, partial and complete septate, bicorporal and uterine diabetes. Now, 3D provides great anatomical detail and information on external fungal contour and endometrial cavity. It's an important diagnostic feature which we have already said. We look for the internal indentation, we look for the fungal contour which helps us to differentiate. Using the CUME in doubtful cases, it gives a good differentiation between these two types of uterus. Septal length, uterine wall thickness, and all using vocal software is more accurate. And 3D is less expensive, less invasive, less time consuming, and therefore the modality of choice. MR is a problem solving modality. But I would like to add one thing here. I have had patients where the patients come with an MR, and then it's very difficult. One such patient where MRI was reported as complete septate. I could not find it. I called up my friend, I called up two radiologists to come to the clinic, and I said, you have to come here and look, I cannot send this image. And they all said it was a normal uterus. So I don't know MR, so I can't really say how it went so wrong. So, and the only other thing is timing of the scan. If we scan them appropriately at the mid-cycle, we get better results. And I always feel if the radiologist recommends too many additional images, it is unlikely that the information of ultrasound is being used. I hope I didn't put you off to sleep. I sent you with a smile. And thank you so much for having me here. And before I end, I would like you to join us for this USCON, which is in Odisha this year on 6th to 8th of October. And I would welcome you all there. I don't think we can extend so much hospitality like you people have done, but thank you so much for having me here.
Thank you, ma'am, also.
Okay, so we have reached to our last lecture of the day of the session. Last lecture will be given by Professor Kanubala, and I find this is a bit unusual topic again. His topic is artifacts and clinical artifacts in gynecology and obstetrics. So please welcome Professor Kanubala. And this is the last lecture of our 27th WFUMB COE workshop in Dhaka. Thank you.
বাই কর্পোরাল মানে বডিটাই দুটো বডি থেকে দুটো বাই কর্পোরাল হচ্ছে
কিন্তু তাইলে আপনি জাইডেল ফার্স্ট এই বাইকের
So now I can occupy
So, relax. Take a deep breath and exhale it. And relax. All the serious topics, then no more serious topics. But this one, though it is not serious, but in our clinical day-to-day practice, that is very important. Very important. There may be some legal implications. Very good. My topic is artifacts and clinical artifacts in gynecology and obstetrics. You know, female pelvis, that is like a Pandora box. You will get everything inside it. Especially in ultrasound, you can manufacture anything inside it. I can remember one day one of my elder brother-like friend, he came to my chamber and he is telling me, it's a very nice picture with a lake, and there are, at the side of the lake, there are so many flowers, and so and so. And I saw it, yes, it is seeing like lake. Lake is the urinary bladder, and on the sides, there are so many flower trees. So, if you want, you can prepare anything inside the female pelvis. But ideally, what is artifact? Artifact, any man-made object is called artifact. But ideally, artifact is the artwork, some man-made artwork, like this one. This is artifact. But in ultrasound, that is a bit different. Here you can see, this is the real picture of our Ramna green, and here is the reflection. This is not real. So this is artifact. This is real, this is not real. This is artifact. Here you can see, this is a structure. And here you can see reflection. This is not real, but this one is real. So this is artifact.
Again, niche yes.
Now, that one is testis, not female pelvis. But here is this one is a female pelvis. Here you can see this is urinary bladder. This is the bladder wall. It is acting like a mirror, and I have found a very big muscle. And in ultrasound, we used to say that if we scan in two planes, perpendicular plane, then we can solve most of the problem. But you see, this is long section, this is transverse section, but still there is mass. So how we can avoid it? First of all, high grade of suspicion. Yes, there may be some problem. That is a high grade of suspicion. Then, if we change the environment, how we can change the environment? Either we can ask the patient, drink some more water, and the bladder is more full, and again scan. So the environment is changed. Or we can ask the patient to go to the toilet, urinate, and then come. Even then, sometimes we can ask the patient, okay, give some preparation to the patient and ask the patient to come the next day. So in this way, we can avoid this sort of artifact. But first of all, there must be high grade of suspicion. Here you can see inside the bladder, there is just like flame-like image. But there is no flame inside urinary bladder. This is artifact. So what is the artifact? Any object present in ultrasound image not present inside body. Not inside body, but in the image. That is artifact. Now, vanishing twin. That is a very popular term in obstetrics. Vanishing twin, that means in the early pregnancy, if we scan, there is 7 to 8% twin. But during delivery, it is only 1 to 2%. That is 1 in every 80 pregnancy. That is the delivery of twin. So from 7 to 8, it comes down into 1 to 2. So 6 to 7% that is vanishing. That is vanished. That is called vanishing twin. But in early papers, they wrote that, they found that there were almost 14% twin in the early pregnancy. So at that time, the percentage of vanishing twin was very high. Why? The machine was not so developed, our knowledge was very primitive. So we used to see this type. You can see here, two side by side, gestational cells. But actually, this is not two. One. This is also some sort of artifact that is called refraction artifact. How we can avoid this? If we scan it in the different direction, we can avoid this. This is the vanishing twin. In many of your house, you have got aquarium. In a certain location, you will see that you have two fish, but you will see it is number 4. That is the refraction artifact. And when we are doing the ultrasound, we are facing this problem. again and again. Here you can see this is a transverse section of uterus, and inside this very bright piece, that is the copper 7. Copper 7. But here you can see that is 2. And this is the refraction artifact. And some author say, just make some joke. This is not copper 7, this is copper 14. 7 plus 7 is copper 14. And also you can see this is the left ovary, one ovary. But in a different picture, you can see there are 2 ovaries. But actually this is one ovary. So either we change the environment by giving more urine inside or urine outside, we change the environment and we can see what is it, or in different direction, then we will find that this is one ovary. And sometimes it is really problematic. Why? You can see here that this is a transverse section of uterus, where the measurement is 5.5 centimeter, 5.5 centimeter. But actually this is not 5.5 centimeter. It is actually 4.5 centimeter. So very difficult, especially during folliculometry. If we are not cautious enough, then the measurement will be wrong. In this picture, actually there are 2 pictures overlapping one after one. So the measurement is more. This happened in prostate measurement also. So we should be cautious. And here this is very common. This is very common reverberation artifact. Each and every patient will get this reverberation artifact. This is very common. And all of us know this is reverberation artifact. But in some situation, this is some uncommon situation. Inside the gestational sac, you will see this one. This is also reverberation artifact. And here, this is either copper T or copper 7, but the shape is so many, so shape is changed. And it can create, especially in case of full-term pregnancy, and the placenta is posteriorly placed, and anteriorly there is a sufficient image of reverberation artifact. We may give the report placenta is anteriorly placed. That can be happened. Because placenta is posteriorly and we can detect it. So we must be cautious. And here another one, missing wall. You see, what is it? This is urinary bladder, very clear cut. But actually the total thing is not urinary bladder. There is urinary bladder at the side of the urinary bladder, that is cyst. Ovarian cyst, and in between the wall is missing. That is a specular interface. When the surface is in the line of ultrasound, then the surface may be missing. And this is called missing wall artifact. And that is not very uncommon. You will get in many patients. You see, there is another patient. So one is urinary bladder, another one is cyst. And in our daily practice, many of our gynecologists, obstetricians, they used to make some complaint that so big cyst, but you didn't find it. But after a person, I am getting a 7, 8 or 10 centimeter size cyst. So this, I think many of the time this happens. And here, that is also another missing wall. What is it? Diverticular. The total thing is not urinary bladder. Urinary bladder and diverticular. Very big size diverticular. And also, what is it? This is urinary bladder. Maybe urinary bladder mass. So diagnosis is very clear cut. But actually not. This is ascites, and this is the urinary bladder. And inside the ascites, there are intestinal coil. This is giving the impression of urinary bladder mass. And you can see another problem. This is urinary bladder, and here a bit echogenic mass, maybe dermoid or like that. But in front of my eyes, within second, it is changing this, from this to this, within second. If it does not change, then the diagnosis may be wrong. So this is also false mass. Here you can see urinary bladder. There may be a stone. Maybe a stone. This is not very clear cut. But diagnosis may be a stone. But actually this is not a stone. This figure is outside the urinary bladder. That is also another type of artifact, lateral lobe artifact. Very difficult. Very, very difficult. In different situations this happens. Not only here, in different situations. Especially in gallstone. There are some echogenic spot outside gallbladder. These artifacts, they pull it inside the gallbladder. So inside the gallbladder, there are some echogenic structure. What is the diagnosis? Gallstone. But after surgery, no stone. So this mistake is not so uncommon. But here, this is another very problematic. Inside the urinary bladder, both this side, there are urine. And inside there is a structure. So no confusion. So this structure is inside the urinary bladder. But in a different section, you see this is clear. And where it is? This is here. Lateral lobe artifact. These images are pulled inside the urinary bladder. Here, this is also another artifact, that is enhancement. This is the endometrium. This is the enhancement. This is not very common, but this is a really artifact. This is an artifact. Where we can get it? When the endometrium is a bit inflamed, or it contains more fluid, especially where there is inflammation or infection, then we may get distal to the endometrium enhancement. So here it is helping us in diagnosis. This is another artifact. Very interesting. This is called Chinese fat artifact. Nowadays, you will not get this type of artifact. Very old type machine, they usually give this type of artifact. This is Chinese hat artifact. You know, some hat with so size and Chinese hat artifact. This is a picture of 1996. Very old picture. Now, clinical artifacts. What is clinical artifact? You will not get this term in any book that is given by me. But because I am not a very renowned author, so this is not spread throughout the other people. Clinical. What is clinical artifact? There are some clinical settings which behave like artifacts, but they are not true artifacts. What is it? This is a patient. Of course, this is male patient, 15 years male. This is the urinary bladder, and at the back of the urinary bladder, there is a very big size mixed echo, a mass. Then I became a bit confused. If it is not male, female, then I can say there may be some ovary or ovary related problem. But as because male, what is it? But then the patient is becoming a bit feeling discomfort. Then I asked him, what is the problem?
Difficult.
The sir, diarrhea from last night. So what is it?
Rectum.
Yeah, this is rectum, full of stool. But here you see, this is the uterus. This is not male. But behind this very big more ecogenic
cul-de-sac.
structure.
Rectum.
What is it?
Cul-de-sac.
Can you imagine what is it?
Cul-de-sac.
And I took the history and the girl, 13 or 14 years girl, she told me that very chronic constipated patient. For last 3 or 4 days, no passing of stool. Then what is it? But it is behaving like a mass. This is not true artifact. This is clinical artifact.
Feces loaded rectum.
And now here you can see another picture. This is urinary bladder. There is a mass. But actually that is not mass. And this one is not urinary bladder. This is a slit. Slit like a space. This is urinary bladder. And this is ascites. Then how we can be sure? We can ask the patient to drink water, stay for another half hour, then again come back. Then we will be sure this is urinary bladder, this is ascites. But by seeing only this picture, it is very difficult to say where is the urinary bladder. This slit-like structure, this is the urinary bladder. So sometimes this happens. Here another picture. This is the urinary bladder. This is a stool with very
shadowing.
nice shadow. But you see, there is the same type of problem. The urinary bladder is collapsed. This is urinary bladder. And this is ascites. Probably there are some structure.
Fecolith.
This structure is like from this area. So this patient is with ascites. What is it? This is urinary bladder. This is a cyst. Very clear-cut diagnosis. No problem. But actually not. This is the urinary bladder. A different shape. Urinary bladder has got a definite shape, but it is not definite whether each and every patient has got the same shape. This is a different shape. For some congenital anomalies, different shape urinary bladder. In a particular section, we are getting this is urinary bladder, this is a cyst. So every time we should scan very meticulously, in both directions very meticulously, before giving any report. Because once we write down any report, then that will create some problem. Now, this is the uterus. Maybe multicystic body. At the side, this is maybe. But actually, what is it? If we ask the patient to drink water, and sometimes they are so hurried, they take lot of water at the same time, and this water goes inside the entire intestine. They just move, and sometimes it comes in the pelvis. And this is actually some author has mentioned it in their books also. So this happened.
Water.
in the
Here you can see another minimal fetal ascites. You see there is a very hair-like line. Very small amount of fluid. Ascites, fetal ascites, very small amount. I have first seen it and I found it inside some literature, and I become confident, okay, this is the ascites, very minimal amount of ascites. And after that, because I am very conscious that this we may get minimal amount of ascites, so after that, within 1 or 2 months, I am getting so many fetus with this fissure, and I become confused. Almost 30 to 40% fetus, they have got this type of fissure. That's because I am very cautious. So I am diagnosing, I am getting every time, 30 to 40 times. Then I become worried. What is it? And I go through the literature. And in on literature, after searching so many papers, in on literature I found that, yes, that can be affected. What is it? This is a fatty layer inside the abdomen of the fetus. So we may get this. If we are very alert, then we may give some overdiagnosis. Then what is it? Seminal vesicle. Very clear-cut seminal vesicle. But no seminal vesicle. Why it is not? This is the female patient. How you will get seminal vesicle? But this is not very uncommon. This is not seminal vesicle. Then what is it? You see here is also seminal vesicle. What is it? Any idea? This patient has hysterectomy. After hysterectomy, we may get this type of hysterectomy. So, history, very important. I used to say my students that history is the part of ultrasound examination. Without history, ultrasound examination is not possible. So every time we must take history. In conclusion, ultrasound is particularly prone to artifacts. Their recognition and avoidance form a major part of skill and art of ultrasound. Thank you.
Thank you, Professor Bala. Actually, he has finished the session in just in time, 3:15. I think. So, he has accommodated all the time we lost throughout the day. So, again, a big thank to Professor Bala. So now, we are on time. The time for tea break. Yeah.
There is no rush.
Maybe a bit early for you, but after the tea break, we'll come here again for the practical session. So I think it's ready?
Yes. Tea break, after tea break you come here. Within 30 minutes you come here. Probably we can show you some TBS examination. That will be another benefit for us.